Well, it's nice to meet everyone virtually. I'm Dr. Gary VOLKELL. I'm one of the general neurologists at MedStar Franklin Square Medical Center. Although my specialty within the field of neurology is movement disorders. I'm the director of movement disorders at MedStar Franklin Square in Baltimore County. And I was asked to speak about Parkinson's disease and specifically with a focus on off periods in Parkinson's disease. So I'd like to talk a little bit about all of that. So we're all on the same footing when we do talk about off periods, I'll start with a little bit of just an overview of what Parkinson's disease is and the symptoms that we talk about when we refer to being on or off. So I do like to start off with just a little bit of the building blocks of this, and then we'll move into talking about on and off periods and how we manage that, some of the different strategies that we have. I don't want to take up too much more of your time yapping, so I'll start here with just a very brief history. Just very briefly about Parkinson's disease. It's named after an English physician, Dr. James Parkinson. He originally described the disease, which used to be called paralysis agitans, but was renamed after Dr. Parkinson by a very famous neurologist, Dr. Charcot, who continued to study Parkinson's disease after Dr. Parkinson discovered it. So that's where the disease gets its name. Here's our very long and complicated medical definition of what Parkinson's disease is. I'm not even going to read it because it's like, what does that even mean, right? So, but we're gonna break down this very wordy structure and talk about what dopamine is and what Parkinsonism is, because that's really when we're talking about on and off periods, we're really talking about how the dopamine is in our body, how it's working, or how it isn't working. So first, again, just to make sure that we have the basics down for Parkinson's disease, I do like to talk a little bit about what's going on in the brain, what's actually changing. And then when we start talking about how we treat that, that's when we talk a little bit about what's happening with these things that I keep referring to with on and off periods. So probably one of the most important things going to be talking about this lecture is dopamine. So dopamine is a hormone. It's a neurotransmitter, so a chemical. It's made in the brain, and it's used to pass signals from one part of the nervous system to another. It plays a big role in motivation and reward, pleasure, and the main thing that I'm going to be focusing on today is its role in our movement, how we move around. This is actually a picture over here. I hope you can see my cursor of the molecule of dopamine. And like I said, dopamine for the most part is made in the brain. It can be found all over the body, anywhere the nervous system is. But it's specifically made in a part of the brain called the substantia nigra. Over here in my picture, it's this red dot. This is kind of if you cut the face in half like I'm drawing here and then looked at it from the side, a profile view, we're kind of right in the middle at the base of the brain here, this red spot. The substantia nigra is made up of a lot of brain cells, so neurons, and those brain cells are really good at making dopamine. It's kind of like a major factory for dopamine production. I want to talk a little bit about the substantia nigra. So that's the words here. Substantia nigra, it means black substance because it really does look black if you could look at that area of the brain. And I will kind of show you a picture of what that looks like in just a moment. But first, let's talk a little bit about how dopamine is actually used in the brain. So first, it gets made in the substantia nigra, and then it's allowed to move around and send important signals to other parts of the brain. And usually the parts of the brain that we're talking about are these structures which all make up this thing called the basal ganglia. So the basal ganglia is just a group of different clusters of brain cells that exist on both sides of the brain. And they're kind of this magenta or fuchsia color here. I'll be honest, when it comes to pinks like this. I have my mother's color blindness, and I call pink things orange, orange things pink, but we'll call it a nice magenta. But these are some of the different structures in the basal ganglia that the dopamine goes to. And all together, these parts of the brain really help with making people have normal movements. So the dopamine leaves the substantia nigra, it goes to the basal ganglia. We have our normal movements. The dopamine gets broken up because it's all done getting used, and then it gets recycled so that you can make some more. And that's kind of the normal pathway of dopamine. So in Parkinson's disease, though, something's not working. And specifically what's happening is you have this abnormal protein, that misshapen protein. It kind of folds into a funny shape, and we call that alpha-synuclein. And this abnormal protein develops, and it can just deposit all throughout the body, including the substantia nigra. And when that happens, when this abnormal protein lands on these or in these brain cells, it destroys those brain cells, and those brain cells die. And then that person has fewer brain cells that can make dopamine. And when people start to have less dopamine in their brains because of this process, they start to experience the symptoms of Parkinson's disease. I have a picture of, if you remember that pink spot on the brain, or the red spot on the brain a few slides ago where I was talking about the substantia nigra, that's this area of the brain here. And you can see, like I called it the substantia nigra before, I mentioned that it was black substance, and you can see these bands over here. Hopefully you can see my cursor on the left cut of the brain here. This is a real brain from somebody who's passed away. And you can see those black bands there, and that's that black substance. That's a normal substantia nigra. So this would be a brain which did not have Parkinson's disease, versus the one on the right over here. And you can see there's kind of those black bands. They're kind of gray color here, but they're not nearly as robust as they are on the left. And this would be somebody who had a disease like Parkinson's. So you can see most of those brain cells have died and disappeared because of that abnormal protein. So now we have to talk a little bit about the symptoms that people experience, and then we can talk about how we treat it and what this whole on and off thing is. So we always break up symptoms of Parkinson's disease into two categories. There are motor symptoms, which are the symptoms that affect the way people move. And then there are non-motor symptoms, which affect everything else, is what I say. It's a nice dichotomy, right? And the primary focus of this talk is going to be on those motor symptoms, because that's really what we're going to be focusing on. I can't help it. I will talk a little bit about non-motor symptoms and how we treat it, because I feel like it's important to talk about, and it is related to the on-off periods as well. But I'm going to kind of save that towards the end. To start with, I want to focus on those motor symptoms. When people have these motor symptoms, these abnormal motor symptoms, we call that Parkinsonism. So when I say Parkinsonism, I don't mean that somebody necessarily has Parkinson's disease. I just mean that when I look at the person, it really looks like they could have Parkinson's disease. That's called Parkinsonism. There's a few different ways people can get Parkinsonism. The main one is having Parkinson's disease, but there are some other diseases that cause Parkinsonism that aren't necessarily Parkinson's disease, things like dementia with Lewy bodies and a few other things that we won't really talk about now. And also some medicines can cause people to have Parkinsonism. They can be perfectly healthy, but they take a medicine and it makes them look like they have Parkinson's disease, and then they stop the medicine and they get all better. But when we talk about the motor symptoms of Parkinson's disease, this Parkinsonism, we're really talking about these four symptoms here. And that's bradykinesia, which is a slowness of movement, rigidity, tremor, and then the changes in the way people walk and keep balance. I'm going to break each of these down because I think it's important to talk about them. And you'll see that bradykinesia, I put the font in a black color as opposed to the white, because this is actually the most important symptom, because you really need to have this one in order to have Parkinson's disease. So we'll talk about that one first. So bradykinesia, like I said, means a slowness of movement. You have to have this symptom in order to really feel comfortable in making a diagnosis of Parkinson's disease. It can be a number of different ways. So slowness of movement can present as maybe not being able to do fine motor movements as well, like tapping your fingers like this or opening and closing your hand like that. But it can present in other ways as well. Any part of your body that moves a lot can get a little bit slower. So we use our face to make a lot of facial expressions throughout the day. Humans are really good at making facial expressions, and when that gets slowed down, we call that hypomimia. You can think of that as hypo means less, and mimia is like expressivity, right? Mimes are really expressive with their faces, so less facial movement. And sometimes we call that a masked face, right? Like when somebody's not moving their face as much, it almost looks like they're wearing a mask. Hypophonia can occur. So again, hypo means less, phonia is your speech. So it's like a softer speech. People can start speaking softer or maybe even start to mumble or become really difficult to understand, have to repeat themselves. And then micrographia, which just means small handwriting. These are different ways that people can show that they have bradykinesia. And, a hypomimia, that masked face appearance, really looks better in person with a video. But you saw the technical difficulties that I had even at the start of this. I'd have even more trouble probably trying to show you a video today. But you can kind of see in this woman on the left that her face does not look like it is in a normal position. She's not paralyzed or anything. She's just not moving it as much. And then on the right over here, you can see the very small handwriting towards the bottom. It's almost to the point of becoming illegible. Just examples of bradykinesia. The second motor symptom I was mentioning is rigidity, which is kind of like a stiffness of the muscles, usually around the joints. It can really be in any joint, and it's very common to see that rigidity, that stiffness in joints like the shoulders, especially, or in the elbows and the arms. It can happen in the legs. It can happen at the neck as well. Sometimes the first time somebody has rigidity, they have a really painful shoulder, for example, and they may see their orthopedist first and say, do I have a frozen shoulder? But it can make people feel like they're not really moving that well. They get stiff and they're having more difficulty moving. So not only can you be slow with your movements, you could have more difficulty because you're not able to move as well because of that rigidity. The third one that I mentioned was a resting tremor. It can be really any type of tremor, but usually it's a tremor that happens when the person is just kind of sitting comfortably, they're relaxed, and then maybe their arm starts to move back and forth. And it's usually pretty rhythmic, almost like a metronome, if you're familiar with that, or like a pendulum on a grandfather clock. But that kind of pattern, like that back and forth. And about 70% of all people with Parkinson's disease have a tremor like this. And most of the time, I think when people think of Parkinson's disease, they think of tremor, but 30% is a pretty big number. So there's still a lot of people who don't have the tremor and they can still have this disease. And like I said before, while that resting tremor, the tremor where the person's nice and relaxed and then their jaw or their arm just starts tremoring, is the most common type of tremor in Parkinson's disease. It can happen in different positions. Maybe they're holding something, maybe they're moving their arms around, and that's when the tremor shows. So it can be a little bit tricky, and that's why when you're getting your diagnosis, it's important to get seen by somebody who specializes in Parkinson's disease, like a movement disorders provider. And that last symptom, which I was calling gait or postural instability, I just think of it as difficulty with the way people walk, they keep their posture, the way they keep their balance. Now, these are things that can just happen as we get older. Our joints get a little bit achier with arthritis, things like that. But in Parkinson's disease, there are sort of some classic things where people may shuffle, where they take really short steps. They don't lift their foot up totally off the ground and they kind of slide their foot across the floor. They may swing their arms less. When they turn around to change direction, they may have to take several steps instead of just 1, 2, or even 3. They may feel like their foot gets stuck to the ground, like it's glued in place and they can't get it up. We call that freezing. And all of these things, as changes in the way people walk, can start to lead people to having more difficulty with balance. So they may start to have trips and stumbles or even fall, which can be pretty dangerous. And people who are experiencing this may even need devices to help them, whether it's a cane or a walker or something like that. Sometimes even a wheelchair if the walking is really difficult. And again, I'm not gonna do too much with the non-motor symptoms right now, with their treatments, I should say. But I think it's important to talk about them because motor symptoms and non-motor symptoms are going to fluctuate with the on and off periods, which we're going to be talking about in just a moment. So those non-motor symptoms, like I said before, right? So dopamine doesn't just affect the way we move. I mentioned a few of the other things that it can affect, right? Our mood and behavior, for example. So while people will experience motor symptoms with Parkinson's disease, they will also experience a lot of other symptoms that don't really affect the way they move. And a lot of times those symptoms can actually start even before people experience the motor symptoms of Parkinson's disease. For some people, it can have a greater impact on their quality of life. And to make things even trickier, when we treat motor symptoms to try to help somebody move a little bit better, the medicines and treatments that we use can actually make non-motor symptoms worse. So I always like to talk about how we kind of walk a tightrope a little bit. You don't want to ever lean too far over from one way or the other. And if you move towards one to try to make one better, you make another one worse. So it can get a little bit tricky when we're managing this. And again, that's why it's nice to have somebody who's experienced trying to help manage all these different things. And we're going to talk about how that gets complicated with these on and off periods. Just to briefly touch on some of these non-motor symptoms, there can be the symptoms that affect the person's mood, their motivation, their behavior. It can lead to things like depression or anxiety or a loss of motivation, which we call apathy. It can lead to becoming really impulsive, like they can't control themselves, where they need to do something like gamble or go on a spending spree. It can lead to things like hallucinations or illusions, so kind of seeing things that aren't there or hearing things that aren't there, for example. It can change the way people think about things, so it can cause memory loss or even dementia. It can cause word finding difficulty. It can cause a slowness of thought. It can cause this thing called dysautonomia. So I like to think of the nervous system as really complex, and we break it down into different parts to describe different things that it can do for us. Most people are pretty familiar with the brain, but that's not the only part of the nervous system. You have this thing called the autonomic nervous system, which is a group of neurons, those brain cells, and nerves in the body, which kind of do all the stuff that you don't have to think about. So, for example, if you were to have a meal, you don't ever have to tell your gut, "Hey, it's time to digest this and move it along and absorb all the nutrients," right? It just kind of happens on its own, and that's what the autonomic nervous system does. It does all the stuff we don't have to think about. But unfortunately, this can be affected in Parkinson's disease. It can lead to things like constipation or a loss of appetite. It can lead to urinary incontinence, drooling, things like that. Parkinson's disease can lead to things like fatigue, numbness and tingling, and a loss of the sense of smell or taste. In fact, the loss of the sense of smell can sometimes happen, years or if not decades before people start to experience motor symptoms, those other symptoms we were talking about. And finally, Parkinson's disease can also affect the way people sleep. It can cause insomnia, where they're not sleeping enough, or it can make them very tired, where they're sleeping too much. It can cause restless leg syndrome, as well as a few other things that happen at night. Things like REM sleep behavior disorder, or RBD for short. It's when people start to have really vivid or lifelike dreams, and they may start to act out those dreams in their sleep. They may punch, they may kick, they may call out in their sleep, they may scream, they may fall out of bed, all while they're sleeping there. It's like they're acting out their dreams, and it can be dangerous for them. It can be dangerous for someone that they share the bed with. So, these are all parts of Parkinson's disease. And just because I'm talking about all these things, everyone's disease is a little bit different. It's really unique to the person. And because of that, just because I'm describing all these things does not mean that every person with Parkinson's disease is going to have all of these symptoms, right? These are all possibilities, and likely a person's going to have some combination of these things, but definitely not all of them. It's pretty unlikely to experience all of them. So here's kind of the meat of the talk, so to speak, with how we treat the motor symptoms. And this is ultimately what's going to lead us to those things that we were talking about, those on and off periods. So since this is a disease that involves a loss of dopamine, because those brain cells that make dopamine start to die and disappear, the treatment involves returning dopamine to the brain and the body. And the way that we classically do this is with a medicine called carbidopa levodopa. That's sort of the mainstay of therapy. It's been around since, I want to say, the 1960s. So it's an old medicine. It's actually two medicines combined into one pill. The levodopa, which is that second word I said, is actually the part of the medicine that gets turned into dopamine. And then the carbidopa is like a suit of armor. It protects the levodopa so that it safely reaches the brain, where the levodopa can then get turned into dopamine and be used to do all the things that we want it to do. When we return dopamine to the brain this way, it's really good at treating those motor symptoms. It's really good at treating bradykinesia, that slowness of movement, at rigidity. For a lot of people, it's really good at treating tremor. For some people, their disease is just very resistant to, or their tremor is very resistant to dopamine. But again, the disease is a little bit different for each person. It has kind of variable effects on the way people walk. And the medicine for a little while was thought to, maybe somebody, if you start it too early, maybe you can become immune to the medicine and then it won't be work later when you really want it to work. And it turns out that's not true. Some very good doctors did a lot of research on that. And it turns out that it doesn't matter when you start carbidopa, levodopa, it always helps. And we're going to talk a little bit about that, but you can't really become immune to it, which is good. The oral version of carbidopa levodopa comes in different forms. There's an immediate release form of the medicine. There's extended release versions of the medicines. There's disintegrating tablets. And it comes with very few side effects. One of the more common ones that somebody may experience, especially if they're increasing the dose of the medicine very quickly, they may get nauseated. And it can cause other things like lightheadedness when you change positions. And at very high doses, it can cause confusion or hallucinations. So like I said, those are some non-motor symptoms we talked about earlier. So when we treat the motor symptoms, unfortunately, it can make those non-motor symptoms worse. I'm also going to want to talk a little bit about dyskinesia, but before we do that, I want to talk about motor fluctuations. So this is when we've been talking about on and off periods, this is kind of what we are talking about. So with Parkinson's disease, when somebody's first diagnosed, or hopefully early in their disease course, most people get put on carbidopa levodopa at least 3 times a day. The medicine does not last very long. So because the dopamine that we get from this medicine doesn't last very long, it needs to be given at least 3 times a day to really give the person good coverage of their motor symptoms throughout the day. And at first, a lot of people have really good control of their motor symptoms with such a low dose. But unfortunately, as the disease progresses, that person loses more and more brain cells that make dopamine, which means that they require higher and higher doses of a medicine like carbidopa levodopa. So as more brain cells die and there's less dopamine in the brain, people need more medicine to give them dopamine back. And that can happen a number of ways. It could just mean increasing how much of the medicine you're taking at each dose. It could mean increasing how many times a day you take the medicine. So if, for example, somebody starts with carbidopa levodopa and they're taking 1 pill and they're only taking it 3 times a day and it works great, maybe as time goes by, they realize that they're noticing that their symptoms are coming back before the next dose. So maybe the person takes the medicine at 9 in the morning, and then 1 in the afternoon, and then 5 in the evening, and that works great for them. But all of a sudden, they've been taking the 9 o'clock in the morning, and before it reaches 1 o'clock, maybe around noon, an hour before their next dose, they start to say, hey, the medicine really used to do a good job of controlling my tremor, And now I notice that my tremor starts to come back an hour before my 1 o'clock dose. What's going on? And not only that, but I take my 1 o'clock dose, and then at 4 o'clock, an hour before my 5 o'clock dose, my tremor's coming back. Or maybe it's not the tremor. Maybe they start to feel more rigid again, or maybe they start to get slower again. Their walking slows down again. And it could be, right, as the disease progresses and more of these brain cells are lost, the person is losing more of their natural dopamine, and they need higher doses of dopamine that they're taking from the medicine. So initially, it may mean maybe increasing. So maybe it's not just one tablet they need to take 3 times a day. Maybe they need to take 1.5 or 2 tablets. And you add that on, and then maybe everything's good again. So going from their 9 o'clock to their 1 o'clock to their 5 o'clock, now that they increase the medicine, they feel like they did before, and everything is kind of back to where it was. But then more time goes by, and more of those brain cells that make dopamine start to die and disappear. And they may need higher doses of the medicine, or maybe they need something else to help them out. But what's starting to happen is that you get these peaks and valleys, and I kind of want to show you what I mean by that. So try to do this graph to kind of give a sense of how the dopamine would normally get released from the brain. So focusing on this red line here, in a regular person, this is kind of hypothetical, it's not a perfect picture, but in a normal person, the brain releases this normal red line amount of dopamine throughout the day. So those people who, and when I say normal, I don't mean everyone's a little bit weird, right? I mean somebody without Parkinson's disease in this case. But somebody without Parkinson's disease, right, their brain releases a steady amount of dopamine throughout the day. And because of that, they have totally normal movements and they don't have any of the symptoms of Parkinson's disease. But somebody with Parkinson's disease is not going to have this steady release of dopamine in their brain because they don't have as much dopamine anymore. So maybe this line would be much lower for them. And instead, they're taking their carbidopa levodopa to try to increase how much dopamine they have. So you can see maybe this is around the time of their first dose, all the way over here at the beginning of the graph, and the dopamine climbs up, but then it starts to wear off, right? So this is maybe 9 o'clock over here. They have a good amount of the medicine here, and then as it gets really close to 1 o'clock, and their medicine is wearing off, they take their next dose, and then the dopamine level rises again, and then it starts to wear off, and as it's getting close to that 5 o'clock dose, they take their medicine, and then it rises again, and then probably they're asleep, right? So that's sort of what's happening. You're getting these peaks and then the valleys. And when you're at your peak, you're having good coverage with the dopamine, and the symptoms, the motor symptoms will usually subside. And then when you reach a valley down here, the medicine's probably wearing off. So when people start to experience this feeling like the medicine is wearing off before maybe they get to their next dose in time, those symptoms may start to return, like their tremor or their bradykinesia or their rigidity. It doesn't just have to be the motor symptoms, though. That's why I talked about the non-motor symptoms. Some of those non-motor symptoms may fluctuate just like the motor symptoms, but most of the time people are going to experience their motor symptoms fluctuating, where sometimes they feel like the medicine is working well, which we call an on period, or the medicine is not working well, like it's just, all the symptoms of Parkinson's disease have come back, and we call that an off period. So this is kind of what we're talking about here. Now, in some instances, all right, you can already start to see that this is imperfect, right? If we look here, this nice red line, which is flat, is beautiful, right? And there's just no way we can reproduce that with medicine. That's why we get these peaks and valleys. The medicine doesn't last for very long, so it works really well, and then it wears off, right? We recycle the medicine, and we have to get more. So because of those peaks and valleys, sometimes, I keep talking about, well, if we don't have enough medicine, people start to feel like their medicine is off, their symptoms come back. But just like you can have not enough, you can have too much medicine too. So we're only supposed to have a certain amount of dopamine. So if you have too much dopamine, you may start to experience symptoms, new symptoms. And I kind of glanced over them before because I knew I was going to talk about them now, but people can experience these extra movements called dyskinesias. So if you don't have enough dopamine, people don't move as well, right? They move less because they're bradykinetic, they're rigid. And if you have too much medicine, too much dopamine, people move too much. And that too much movement is dyskinesia. So those extra movements can be all sorts of things. People can rock or sway like I'm doing now. Their legs may twist to make it look like they're dancing a little bit, for example, or they may cross their legs to prevent their legs from kind of moving around and maybe even flailing a little bit. Again, they may rock, sway, and that can happen while they're sitting down. It can happen while they're standing up, and it can make them unsteady and put them at risk of falling. He hasn't been on camera much recently, but Michael J. Fox, who famously has Parkinson's disease, when you could see him when he was getting treated with the medicines, he would really rock and sway almost like he was dancing a little bit. And that's because he would have been over-medicated on a medicine like carbidopa-levodopa, or one of the medicines that help it. These dyskinesias typically occur after somebody has just taken their dose of medicine and that they're highest of highs on the medicine because they have too much. But paradoxically, it can also happen at the lowest of lows. Again, this disease is a little bit funny and it's unique to the person, but classically, I think of it as having too much medicine causing too much movement. Different things can also contribute to that beyond just the medicine. We talked about how with Parkinson's disease, it can lead to constipation. And certainly if you're constipated, you may not be absorbing things as quickly as you otherwise would have in your gut because everything slows down. So that slow absorption of the medicine may lead to feeling off because you don't have quite as much medicine because it's taking longer to get into your brain. And believe it or not, having a really high protein meal, like a big steak dinner or lots of chicken, for example, that protein, when it reaches your stomach, if you take the medicine at the same time, the carbidopa-levodopa and the high protein meal, the big steak, they both fight to get absorbed by your gut at the same time. So sometimes when this is more of a problem, those on and off periods are more of a problem, taking the medicine at the same time as a really big, heavy protein meal may make the medicine feel like it's not as effective. So in those cases, we tell people to maybe space out their meals when they're taking their medicine, or if they know they're having their medicine, then to maybe not have like a big, hearty steak dinner, for example. I really love this picture because it gives you a sense of how these on and off periods occur throughout the disease. So you can kind of see this arrow at the top here. This is supposed to tell you a little bit about how severe the person's Parkinson's disease is. So mild would be early in the disease course. As more of those brain cells that make dopamine are destroyed, the disease gets more severe. So moderate, that's like a medium stage, until finally it's very severe at the end here. So going from left to right, we're seeing mild disease going on to a severe version of the disease. And everything in this kind of white space here, we call the therapeutic window. This is when the medicine is working great. People don't feel their symptoms. They feel on, right? This is their on period here. And you can see this black line represents when the person is taking their medicine. So they take their levodopa, the carbidopa-levodopa, their dopamine level rises, then it falls. They take their next dose, it rises, it falls. But as the disease goes on and there's fewer and fewer brain cells, we start to become more likely to experience on and off periods. So this kind of dark bluish color at the bottom here is when the medicine isn't really covering those motor symptoms. These are the off periods. And then this light blue or kind of gray color up here is the dyskinesia. This means that they have too much medicine. And you can see earlier in the disease, the white space, which is the good space over here, is pretty big. and you're not as likely to experience a dyskinesia or an off period. But even when you're taking the same dose of the medicine, as the disease goes on and gets worse with time, you can see it becomes much easier to experience dyskinesia, those extra movements, and much easier to experience that wearing off phenomenon where people feel like all of their motor symptoms have returned. You can see that they tried to break it down a little bit further here. I like this as well, where, as the dopamine is wearing off and you reach the off period, you can actually feel like the medicine is wearing off. The person takes their next dose at the bottom over here, and then they may even have a delayed on period where it takes maybe 30 minutes before the medicine kicks in. They start to feel it, they feel good for a little bit, and then bam, they start to have those extra movements. As the medicine wears off again, they start to feel like their normal selves or with improved symptoms, and then they start to wear off again. So you can see it's very cyclical. And again, early in the disease, the symptoms are more easily controlled with the medicine. And as the disease goes on, people are more likely to experience wearing off, where they feel like the medicine isn't working as well, and then dyskinesia, where it's working too well and it's making them move too much. This is sort of, again, it's one of my favorite pictures, and it gives a really good idea of what's happening with the disease, what's happening with the medicines when we're treating people, and why people experience wearing off or dyskinesia at all. And it's just because that therapeutic window, the effect of the medicine, the effectiveness of the medicine is going to change as the disease gets worse because of fewer brain cells that make dopamine. So how do we manage this, right? So we see this problem. What can we do to make it better? And truthfully, there's kind of three main things that I think of. One is what I was kind of describing before. Oh, sorry, this is my lady walking the tightrope and in high heels, no less. But right, like I said, when we're managing medicines, when we're managing this disease, we walk the tightrope, because if you have too much of the medicine, you move too much. If you have not enough of the medicine, you don't move as much, right? So this is what I'm always thinking about. But the first thing to do, right, if somebody's feeling that wearing off, like I was saying, it could just mean that you have to adjust the carbidopa-levodopa dose. That can mean increasing the dose, like I was describing in that example earlier, going from maybe 1 pill 3 times a day to 2 pills 3 times a day. It could mean that you increase how many times a day you're taking. So instead of taking 1 tablet 3 times a day at, I think I was saying 9 a.m., 1 p.m., and 5 p.m. before, maybe now the person takes it at 9 a.m., 12 p.m., 3 p.m., and 6 p.m., right? So now they're taking a 4th dose, and it's giving them more coverage throughout the day. Because in that first example, the medicine dosing was spaced 4 hours apart, and in the second example, it's spaced 3 hours apart. That way, maybe they were wearing off at 3 hours, but if they're taking the medicine every 3 hours, they may not feel like they're wearing off anymore. So it's a great way to try to avoid that. Another thing would be to, we're giving people dopamine. Is there a way to make it last longer, right? If it's just each dose of the medicine is wearing off maybe 30 minutes before the next dose, and we just need a little something extra to push it a little bit farther, but we don't want to increase the dose of the medicine, and we don't want to increase how often the person taking the medicine. Is there something we can do to make the dopamine last a little bit longer? And there's some medicines that can do that. And then, of course, there are some surgical options that can help us with this problem. I want to talk a little bit about some of the other medicines that we use besides carbidopa-levodopa. There are these class of medicines called dopamine agonists. So carbidopa-levodopa puts dopamine back in the brain. A dopamine agonist is not dopamine, but it can activate the dopamine receptors and trick your brain and body into thinking it has more dopamine than it does. What's nice about medicines like this is that they last a little bit longer than the carbidopa-levodopa. So one of the tricks we use is to use another medicine that lasts longer than the carbidopa-levodopa. I put some of the big names here, pramipexole and ropinirole particularly. I'm going to talk about apomorphine or apokin on another slide for something else. And somebody say, well, why don't we just use these if it lasts longer? Why not just start with that? And sometimes we do, but the side effects are a little bit more severe. The older we get and the farther along in the disease course people get, the more more susceptible people are to experiencing the side effects of this medicine. And that can be beyond just the nausea we talked about before. As a reminder, the hallucinations, people may become impulsive. They may start to just suddenly fall asleep, which we call sleep attacks, can really make people confused. So we just have to be careful if we're using medicines like this, because while those symptoms, rather side effects, exist with the carbidopa levodopa, they're a little bit more severe in a dopamine agonist. So there's trade-offs, right? Pros and cons to everything we do. There are another class of medicines called COMT inhibitors. These are medicines that basically tell the dopamine to hang around for longer. So I kind of described earlier, after the dopamine has bound to its receptor, it's done its job, it gets another molecule comes along and it breaks up the dopamine and it recycles it. A medicine like this tells that molecule that breaks up the dopamine, the recyclers, it says, wait, hold on a second. Why don't you just wait and let the dopamine hang around for a little bit longer, because we just don't have as much. So this medicine's really good. Something like entacapone, or one of the newer medicines called opicapone. The way it works is, like I was describing earlier, if maybe the medicine works really well, but it's just wearing off about 30 minutes before the next dose, and we just want to push the dopamine a little bit longer, we want it to hang around for a little bit longer, we add a medicine like this, and it allows the dopamine to hang around for a little bit longer to really close up that off period. It kind of gets the person from wearing off about 30 minutes before the next dose to closer to the next dose, so they don't feel like they're wearing off. Another family of medicines that does a similar thing are these things called monoamine oxidase B inhibitors, or MAO-B inhibitors, or MAO-B inhibitors. Very similar to the last set of drugs, but instead of it tells a different set of recyclers to slow down. So there's different molecules that can all help recycle the dopamine. So we have different medicines to target different ones. Rasagiline and selegiline are good examples of those. We talk a little bit about surgical treatments. There's a carbidopa levodopa version of surgical treatments. So I was talking earlier about, wouldn't it be nice, I'll kind of flip back to the slide that I showed at the beginning here. Wouldn't it be nice if we could just get back to this red line where there's a steady release of dopamine instead of the peaks and valleys that we see here that we get with the oral medicines? Well, there is a medicine, a different version of the carbidopa levodopa, specifically the levodopa, where it comes as an intestinal gel. The brand name was called Duopa. And what happens is somebody gets a surgically placed tube into their gut. So this is kind of the cartoon picture of that. You can see the gut over here. There's a surgically placed tube that goes right into the gut here, deposits right into the intestines here. It's hooked up to a pump, and the pump releases a steady amount of levodopa as a gel into the intestine. What's nice about that is, instead of getting those peaks and valleys that people get from having to take an oral medicine, this can release a steady amount of the medicine throughout the day to really help avoid those wearing off periods and those dyskinesias. Well, obviously, it requires a surgery and maintenance of that tube, which is called a J tube or a PEG J tube. And there's always risks and benefits to that as well, right? Whenever somebody has a surgery, especially in their gut like that, there's always a risk of things like infection. Having a line like the intestinal tube in place, it can get blocked up and need to be cleaned out, or it can lead to things like infections. So obviously that there's a certain amount of risk to this, but in somebody who's really having a narrow therapeutic window with high peaks and valleys, where they're really having dyskinesia or off periods, this may be a really good treatment for them. Another surgical option is this thing called deep brain stimulation, or DBS for short. And not to dwell too much on this, because I could spend a whole nother hour just talking about deep brain stimulation, really all of these things. The idea behind it is a little metal wire gets placed into both sides of the brain, goes to a very specific target. Those metal wires are hooked up to a battery pack in the chest, kind of like where a pacemaker would go. It looks a little bit like that. And those wires are allowed to release an electric current into a part of the brain which stimulates the brain kind of like how dopamine would normally stimulate the brain to do its job. So you can think of it as, instead of getting a chemical like the dopamine from an oral pill or from that intestinal gel, the current from this device is mimicking that. And again, that can allow for a more steady state of therapy. Often with deep brain stimulation, people still need to be taking some form of medicine like carbidopa, levodopa, but it can help make that therapeutic window a little bit easier to achieve and allow for fewer off periods and more on periods, hopefully with fewer dyskinesias as well. I'm not going to dwell too much more on this because, again, I think that it's something that I could talk all day about. I'd be happy to. But again, this is deep brain stimulation isn't just used for Parkinson's disease. It's used for a number of different things. But when we're talking about Parkinson's disease, we're usually focusing on very small specific parts of the brain in the basal ganglia, like I mentioned before. Once the device is in place, somebody like a movement disorders provider who has experiences with this can program the device to make sure that the person is getting a good amount of current in their brain so they have really good response, not so many dyskinesias, not so many off periods, and hopefully it can improve how the person feels with their motor symptoms. Obviously, since this is a brain surgery, there are risks and benefits. I'm not going to dwell too much on that, but that is something that, if this is something that people are thinking about, this would be discussed with their movement disorders provider, with the neurosurgeon, and people would also talk to somebody like a neuropsychologist as well. And that's all part of, people really have to make sure that they have a good response before we would consider a neurosurgery like this. Because if we're gonna do a big brain surgery, we want to make sure that the person's gonna have a really good benefit, not just a little something or nothing at all. Kind of the last main thing that I want to talk about is these things called unpredictable off periods, sometimes called complete dose failures. And an unpredictable off period, right? So I was describing predictable off periods. So if somebody were having their medicine at 9 o'clock, and the next dose is at 1 o'clock, and the next dose is at 5 o'clock, and every day you know that 30 minutes before your next dose, the medicine's going to wear off. That's pretty predictable, right? If you take your dose at 9 o'clock, you do well. Then at 12:30, the medicine wears off. You take your 1 o'clock dose. 30 minutes later, the medicine kicks in. You do great. And then 4:30 rolls around, the medicine wears off. 5 o'clock, you take your dose. The medicine kicks in 30 minutes after, right? That's pretty predictable. But what happens if all of a sudden, 9 o'clock, you take your medicine and nothing happens? And you just feel off, like you didn't take any medicine at all. And then 1 o'clock rolls around, you take your medicine, and then you feel good after 30 minutes, right? That's an unpredictable off period. You weren't expecting that. Nobody's expecting that. Or what if some days 9 o'clock dose works great, you take your 1 o'clock dose, it works for 2 hours, and then at 3 o'clock, it just stops working. Well, that's much shorter than stopping at 4:30. And maybe it's not every day, maybe it's just some days. Well, that can be pretty unpredictable. You can have that complete dose failure where it feels like a dose doesn't work at all. And again, these are problems that start to occur later on in the disease, just again, because of the way the disease progresses and injures those brain cells that make dopamine. So in cases like that, where people may have these unpredictable off periods or a complete dose failure, it's nice to have a rescue medicine available rather than just waiting, feeling off like the medicine's not working for maybe even hours until the next dose is due. So there are some medicines like that. I'm really just going to focus on two here because I know that we're getting close to the end of time on the time I have for the lecture, and I don't want to keep people up too late. But there is one version of carbidopa levodopa which comes as an inhaled powder. It goes by the brand name Inbrija. I normally don't like to talk about brand names, but everything is called carbidopa levodopa. It makes it hard to know which one we're talking about. Sometimes it's a little bit helpful to have the brand names just to know what we're talking about. This is the capsule device that it comes in. It breaks apart like this, and what happens here is you can put a capsule of this carbidopa-levodopa powder in here. You place this mouthpiece on, you crank it tight, and then you inhale. You put your mouth on it, almost like an inhaler would look. It's just kind of a different shape than a typical inhaler. And what that does is, instead of the medicine getting absorbed through the gut, which is how we would normally take an oral pill, gets taken in through the lungs. And we use something like this as a rescue medicine when somebody has an unpredictable off period, right? Maybe they took their 1 o'clock dose of the medicine. It should last them until 5, and they're out shopping in the grocery store, and then at 2 o'clock, it's like their medicine just stopped. It was an unpredictable off period. And now it's like they're going to be 3 hours off, right? That's no good. And maybe it takes about 30 minutes for the next dose of medicine to kick in. What are they supposed to do while they're in the grocery store? That's not easy. So instead, they can take this as a rescue medicine where they inhale it. Usually it's 2 capsules. You inhale it once, then inhale it again. It gets them moving again. And then they can take their next dose of their medicine maybe a little bit early. That way they can get through their shopping experience without any issue. That's the idea behind this as a rescue medicine. The second one, which I kind of briefly talked about earlier on the dopamine agonist page, is this thing called apomorphine or Apoquin. I know it has morphine in the name, which is scary sounding for some people. It's not a pain medicine like morphine. It really is a dopamine agonist like I was talking about. And this is an injectable where the medicine comes as a little liquid and you inject it just like any kind of other injectable medicine that you could do. And again, this could be taken as a rescue medicine. For a few years, there was a sublingual film of this medicine called Kinmobi, but I believe it was just taken off the market in the US. It may still exist in other countries like the UK, but I think it was actually, or I want to say earlier this year that they stopped producing it, unfortunately. But Apoquin, the injectable version of apomorphine, is still available. And in fact, they are even looking into making subcutaneous pumps of this medicine, which they sort of started doing, as another way to really help reduce off periods and improve on periods. So again, this is just another rescue medicine that's available. I know that I was going to talk a little bit about treating non-motor symptoms. I think that's probably less important for the scope of this, and we're kind of towards the end of the time. I really mostly wanted to talk about the on and off periods. The only reason that I mentioned the non-motor symptoms is because these can also fluctuate with on and off periods, and the treatment kind of works out to be about the same. So for the sake of time, because I see that there's some questions popping up, I wanted to answer questions. I'm going to really quickly kind of skip to the end here and see if there's any questions that people have now, and also to thank people for their time. I know I ran a little bit later than I had hoped because of my technical difficulties.
So I've got the questions here, at least some of them that people submitted earlier. Mm-hmm. And one is, what strategies can help to regain a sense of control over your life and improve your quality of life when you have Parkinson's?
Okay. So I guess it kind of depends on which part of Parkinson's disease we're talking about, if I understood that correctly. So there's a lot of different things that can be done to try to help improve quality of life in Parkinson's disease. This was a pretty narrow focus for this lecture because we were focusing specifically on managing those motor symptoms, which, as the question asker is kind of pointing out, that's not really the only thing that's happening, right? And I even skipped over some of the non-motor symptom things. So one of the things that we do, right, is manage on and off periods to try to improve that with the medicines. And that's what we were talking about today. But there's other things in general that can help improve quality of life in Parkinson's disease. Probably the most important thing, even more important than the medicines that we were talking about, is aerobic exercise. Aerobic exercise, which is something that gets the heart racing a little bit. But studies show that doing 30 minutes or more, at least 3 days a week of aerobic exercise has been shown to slow down the rate of disease progression. So what I mean by that is it slows down the destruction of those brain cells that make dopamine. And aerobic exercise can come in anything, like from any form, from walking, running, using a stationary bicycle, dance, tai chi. There are these no contact boxing courses, which go by the name Rocksteady in Maryland and a few other places. There's aquatic therapy, MAPS, the Maryland Association of Parkinson's Disease Support. I'm butchering their acronym. I apologize.
Just maps. Just say maps.
MAPS, thank you. Okay, I appreciate it. But what you're all here listening to right now, they have wonderful resources, which are gonna be able to point you out to some of these things, right? Maybe where you are. Um, so there are different things like that. But yeah, so in terms of improving quality of life, doing things like aerobic exercise is excellent. Having somebody who's going to help manage medicines to really optimize the on state of the medicine without running into off states or dyskinesias is also going to help improve quality of life. And also having a provider that's going to address non-motor symptoms as well. And it may not just be a neurologist, right? It may be somebody like a specialist in mood to help with mood, right? Or even a gastroenterologist if the constipation is very bad, and primary care provider. It's going to be a team effort. And I hope I answered that question, Judy. I was quite long-winded, so I apologize. I hope I answered your question.
Let's see here. There's another one here. Is Rytari always an improvement over Cimet?
Cinemet?
Cimet pills.
Yeah. So there's some brand names in there. So I'll break that down. So I know I keep saying carbidopa levodopa. The old brand name was called Cinemet. And this was, again, back in the 60s when the medicine was created. And it's been around for so long that you really only get generic pills, but which is the carbidopa levodopa, but that's a mouthful. So a lot of people still like to call the old kind of extinct brand name, which is Cinemet. And the question was about this other pill called Rytari. And Rytari is, I kind of briefly talked about how the oral form of carbidopa levodopa comes as immediate release pills, extended release pills, and disintegrating tablets. So one of the extended release versions goes by a brand name called Rytari. And Rytari is a longer acting version of the carbidopa levodopa. And the question that was written was, is Rytari always an improvement, the long-acting, the extended release version of carbidopa levodopa over the immediate release, which is the main one I was talking about? And the answer is no. For some people, they may get a lot of benefit, but a lot of people will do really well with the immediate release pills in the beginning, and maybe even jumping to that extended release Rytari early on. People may start to really experience those symptoms way too early, like they're getting too big of a dose for too long, and they may have those dyskinesias and things like that. But that's not to say that one is better than the other, only that they are different tools that can be used effectively to help people at different parts of the disease. So I would not say that one is better than the other. I would say that they both serve different roles depending on what the person who has Parkinson's disease, what they need specifically. Hope that answered that question.
So I've got a few more questions. I think you've probably already touched on them, but I'm going to just ask them anyway. Does everyone eventually have dyskinesia?
That's a really good question. So like I was saying earlier, I hate to say that everyone will always have something, right? I hate speaking in absolutes with Parkinson's disease because everyone is different. Anyone who has this disease, it affects them different. It affects them uniquely. So the answer is we don't know exactly what's going to happen to each person. We have a pretty good idea because a lot of people have this disease, and there's a lot of similarities, but everyone's going to be a little bit different. Some people are going to have a really good response to certain medicines. Some people are not going to have a good response to certain medicines. Some people are going to have tremor. Some people aren't. So to say that everyone will 100% definitely get dyskinesias, I can't say that for certain. In general, though, as the disease progresses, most people will probably experience some form of dyskinesia as the disease goes on, and the carbidopa levodopa dose or the additional helping medicines increases with time. then it increases the chance of having a dyskinesia. So I won't say that everyone will have it, but I will say a lot of people probably will, and it's a pretty normal progression of the disease.
So I think you've already answered this one, but what medications are available to reduce off times and or dyskinesias?
That's
Feel-
wonderful. Yeah. So I didn't talk about the medicines for dyskinesias, um, but as much. So, um, but hopefully I answered the ones used for treating off periods. So the normal medicine we use is the one that we use to treat off periods. We talked a little bit about those rescue medicines, like the inhaled powder of carbidopa-levodopa, the apomorphine injection. But truthfully, it comes with managing the standard medicines of things like carbidopa-levodopa or those helper medicines to extend the lifespan of the dopamine to reduce those off periods. Now with dyskinesias, right? Again, we're walking that tightrope, and we never get it perfect, right? We got those peaks and valleys. We're always leaning a little bit more one way or the other, where we're feeling a little bit more off or a little bit more dyskinetic. And some people will say, I'd rather be a little bit more dyskinetic than ever feel off. Then the question is there anything we can do for those dyskinesias? And there are some medicines that can help with reducing dyskinesias. The main one that I think of is this one called amantadine, which I purposely didn't talk about today because that's a little bit beyond the scope because weren't focusing so much on dyskinesias. But it can be very helpful at reducing dyskinesia. It comes with some pretty hefty side effects, like all of these medicines can when people are more advanced in their disease, or as we get a little bit older, we're more susceptible to side effects. So it can cause things like confusion, this lacy discoloration of the skin called livedo reticularis, which is cosmetic and goes away if somebody stops taking the medicine. Things like that, just for example. And but if, again, that some of the medicine options aren't working, that's when we talk about those surgical options like the intestinal gel version of carbidopa-levodopa, deep brain stimulation. So it doesn't fix the dyskinesias, but it reduces the chance that you're out of that therapeutic window, right? Because in addition to improving your on time, we're hopefully reducing your dyskinesia time and your off time, right? That's the idea behind these therapies. We may not be fixing the dyskinesia, but we may be doing things to kind of get us in that narrow therapeutic window to reduce those off periods and dyskinesias.
So you mentioned about protein,
Mm-hmm.
but so the question was, does eating certain foods interfere with the absorption of carbidopa-levodopa? And I guess the answer is yes.
Yes. So yeah, absolutely. And it's mostly just protein. That's the main thing that I think of. And early in a disease where people are not having these motor fluctuations, those ups and down periods, they probably can just eat their regular diet and it's not an issue. Again, everyone's a little bit different. So it only matters when somebody may be a little bit more advanced and they start to say, hey, I had my dinner, I did have steak or something. I'm just using steak as an example of a protein. And my evening dose of the pill didn't work as well. What should I do? And then we say, let's just space out the dinner time and the pill time, or maybe be a little bit more moderate with how much of the protein we're eating if we need to take the pill at the same time as dinner. Because, as we're saying, it can reduce the absorption of the levodopa.
What are the risks of taking dopamine too often? So you talked about the dyskinesia, but are there other real, serious risks?
Absolutely. And like Judy's saying, right, there's the dyskinesias is a risk, right? So taking the medicine more often or at higher doses increases our chance of having a side effect. Dyskinesia is one of them that can make people unsteady. It can make them fall, which can be dangerous. They may experience nausea. They can experience some of those non-motor symptoms like psychosis, which are things like hallucinations or illusions, which can be upsetting and sometimes dangerous. It can cause things like a lightheadedness when people change position. So higher doses of carbidopa-levodopa can drop people's blood pressures, especially when they're changing position, which can cause people to become lightheaded, dizzy. It can even cause them to faint and fall. So those would be some more of the dangerous things that I think of at of taking the medicine either more frequently or at higher doses. And those are, again, we talk about walking that tightrope, right? We do our best, but we're not always perfect. So this is where having a conversation with the doctor who's managing these medicines with the person who has the disease, that's where those conversations are important to know, to say, what do we think is the best choice forward with how we're managing the medicines to avoid those things that we don't want to happen.
Can extended release be used with rapid release to deal with the ramp up problems?
Yes, it can.
Okay.
We talked a little bit about Rytari. The idea behind that is you get about a third of the medicine like immediately, and then the other 2/3 are extended and they're slower acting. Sometimes people will do a combination where those extended release ones and the immediate release ones will be used together. That way people get they don't feel like they're off for so long, right? It ramps them up quickly, and then the extended release keeps them going for longer. But yeah, it's that kind of creative thinking you come to see the doctor for. But the fact that you're thinking about it shows you that you have a pretty good grasp of what we talked about today. Because that's exactly right. You think about all of those things to try to really improve upon uh, the periods where people are really feeling on. But that's exactly right. That's a real strategy.
I don't have any other questions. Nothing else
Okay.
came in, but I want to thank you so much, particularly for the very graceful way you handled the trouble in the beginning,
Oh, no worries. Yes.
whatever the trouble was.
Yes. We figured it out. We got to do this. So
Right, right. I want to thank you. For all of you listening, I want to remind you to please, you will get an evaluation at the end, after we say goodnight. Please fill it out. We really need to have answers to the questions. And we need to know how you feel about what we're doing. So please, please, please fill out the evaluation. And thank you again. Thank you.
thank you so much for having me. I'm glad to be here.
Okay, I'll email you later.
Sounds good. Take care,
Thanks.
everyone. Good
Thank
night.
you. Good night, everybody. Good night.